Okay. So the first, let me thank you for having come here. And I must thank two doctors, especially Dr. Thu and Dr. Hui. This conference is being organized by the International League Against Epilepsy, or the ILAE. Unfortunately, they coined this word, this name for the International Epilepsy Society more than 100 years ago, when it was called the League Against Epilepsy. So now, of course, the concept has changed. So the ILAE has a task force for dietary therapies, because dietary therapies in epilepsy has been ignored for many, many years, though it is 101 years old, for obvious reasons. Who's going to sponsor a dietary therapy meeting? No one. There's no pharma industry interested in it. But Dr. Thu and Dr. Hui, I contacted them, and I can tell you, in such a short period of time, in 2 months, they put all this together with getting the faculty from all over the world. When the ILAE task force chief asked me, do you think you can do it in 2 months? I said, of course, with people like Dr. Thu and Dr. Hui, we can do it in 1 month. Because the others on our task force said we need minimum of 6 months to organize something like this. So, congratulations to Dr. Thu and Dr. Hui. Dr. Thu is there? Okay, so Dr. Thu is always, very, very reluctant to come into the limelight. But I can tell you she's had a difficult time with 6 of us. Because every time something gets changed, and, we change. Even now, we have changed some of the presentations. So please bear with us. This is a workshop. This is not a conference. So at any time you want to ask me anything, in between even, put up your hand and I will answer. You don't have to wait till the end. Okay, is that okay, Dr. Hui? Being a workshop, we want interaction. In conferences, you listen to the fellow, you get out, and then you forget what he said. I don't want that. This is for you to learn how to use the ketogenic diet, 101 years old, and actually more than 2,400-year-old concept. So let's begin with the history of the ketogenic diet. And you have to know what is the mechanism and the history. Like when I come to Vietnam, I know all about your history. I know about Ho Chi Minh and what a great person he was, and about how they defeated the Americans over here. We know all of this. We've lived through it. So if you know the history, and the next slide, who's handling the slides? Or do I do this? Okay. Okay. So here it shows you 400 before the Common Era, Hippocrates said that epilepsy is not sacred, it's not a visitation, it's not a prophecy, it's not like someone has entered your brain and created black magic. It's natural, and it can go with purging and fasting. Purging and fasting. And now we know that both of them, it was absolutely on the spot. The Bible says the same thing, but only till 1921, when Wilder actually talked about the ketogenic diet. So you had Wilder in 1921. And then what happened in between? For 60 years, until the 50s and 60s, the ketogenic diet was doing great. People were using it all over USA and Europe. And then it fell out. Why? Because medication was available. So Dr. Houston Merritt, you must have heard of him, the founder of phenytoin, he said, I have done the greatest disservice to those with epilepsy, because now no one will be interested in the ketogenic diet. And that's what happened. So the only person who was using the ketogenic diet was Dr. John Freeman of the Johns Hopkins Hospital. I was very lucky to be invited there as a professor, and I worked with him in 1996, and we began the first center in Asia in 1996. So 25, 26 years old. And then Jim Abrahams had Charlie who had these seizures, and he set up a Charlie Foundation. He's a Hollywood and TV movie producer. And then the spread of its wings. So now it's entered metabolic therapies in cancer, Dr. Thomas Seyfried from Boston. So now I may go a little faster. So now it involves, you can use the ketos for cancer, dementia, Parkinsonism, progressive, go on. So let's go to the next and see, this is my guru, Dr. John Freeman. And they are the ones who I have to thank. This is Charlie, 100 seizures a day, surgery and medication, nothing happened. And that's Charlie after he got well. Within a month, he was off all his drugs. Imagine. And he started the Charlie Foundation, which helps to set up the neurological ketogenic meetings all over the world. That's Dr. Freeman and Miss Millicent Kelly, the dietitian with whom I work. And that is Charlie, who's now a school teacher. They said he's going to die. All the doctors said he's going to die. Don't come back to us. So in Asia, 1996, then South Korea, Australia a little later, and then in Pakistan, Malaysia, and in China, and now it's all over. So the number of centers, as you can see, is maximum in China, as you can imagine. They are very, very good at organizing things. Very good. And the types of KD used in Asia are all of different types, which include the classical, the modified Atkins, the MCT ketogenic diet, etc. So what is epilepsy? This is important for you to understand what is ketogenic diet. So a seizure is an abnormal electrical activity. If you have multiple seizures, then you call that person as having epilepsy, right? But in order to get epilepsy, you have to have something called epileptogenesis. You have to develop enough abnormal electrical activity to actually create and generate seizures. So it's a process by which this happens. So initially, there is a head trauma, stroke, infection, febrile, there's a whole lot of things which can happen and which may be repaired or not repaired. If it's repaired, nothing happens. If it fails to repair, then you could either have still no consequence, you could still have that scar in the brain, or it could go into epilepsy known as epileptogenesis, right? And that causes functional and structural brain alterations, the latent period being days to months to years. And then you get both spontaneous seizures and cognitive abnormalities, and it progresses into epilepsy. And very many of them will be pharmacoresistant. So that's your action potential. All of you understand what is action potential: sodium entering, depolarization, potassium leaving, repolarization, etc. So you can have a normal EEG, and then you can have these spikes, which is still not a seizure. And if you get a train of them, you get a seizure. I'm not going to go into the details of that, but here you have dysfunctional sodium channels or abnormal potassium channels. One causing continuous depolarization and a hyperexcitable state, or less of repolarization. You also have two main transmitters, GABA and glutamate, which are inhibitory, GABA, and excitatory, glutamate, and the NMDA and the non-NMDA. So why do we not get seizures here? Because our GABA and glutamate, or inhibition and excitation, are balanced. Very simple way of looking at it. There's so many other things involved, of course. So if the GABA becomes less, the potassium channel activity becomes less, the synaptic activity becomes less, or if the glutamate is more, you have more excitatory activity, more sodium channel activity, more of excitatory synaptic activity, and that network gets active, the network which is going to cause the seizures. So there is an initial mechanism, these abnormalities, then latency period, and then you have epilepsy. And this is where the whole thing changes. So you can do nothing in this period with your medication, now known as anti-seizure medication. I hope you all don't call it anti-epileptic medication. Do you still call it AED? Dr. Hue, do you still call it anti-epileptic drugs? Or do you call it anti-seizure? So it's anti-seizure because it does nothing to the epilepsy. So it can work only in seizure suppression. It cannot modify the disease. So modification of disease, you need metabolic therapy initially here or here. That's the only thing that's going to change, right? And what happens? The old anti-seizure medications controlled about 65%. With all the so many 20, 30 years work, we've only increased that by 5 to 10%. That's it. We haven't gone above 70 to 75%. So the rest are going to be resistant. And the drugs work in very few ways. They either enhance inhibition or they reduce excitation. So you can see here that this is how the drugs work. They have usually one or two modes of action. Just one or two modes of action. So epilepsy has got so many different things that are becoming abnormal. So obviously some medications are going to work in some and not going to work in others. So do they stop seizures? Anti-seizure medications, yes, but they don't halt epileptogenesis. They do not prevent recurrence. They cannot repair the damage to the brain. They cannot stimulate stem cell or neurogenesis. They cannot reduce the triggers of acquired epilepsy. And they cannot reduce the genetic causes of epilepsy. That can only be done by what I call as the iceberg phenomenon. What you're seeing on the top are the anti-seizure medications, which are neither curative nor preventive, but seizure suppressors. And the last line, the recurrence rate in non-idiopathic generalized epilepsy is 25 to 30%. In IgE, anywhere between 20 to 100%. Like in a juvenile myoclonic epilepsy, you try and withdraw seizures, almost 99 to 100% is going to recur. So what are ketones? Ketones are naturally produced from fat and called as ketogenesis. It occurs in the liver, obviously. And what is ketolysis? It's the breakdown of the fats. So ketogenesis is controlled by insulin and the glucagon. So that's your ketogenesis, where you have a ketogenic diet, you've got fatty acids, it gets in, and you've got beta-hydroxybutyrate acid, acetic acid, and acetone. This all in the books. You don't have to even look at it. Oh, nowadays it's in the Google, sorry. You people don't look at books. So it's in the Google. So ketogenesis is the method or the metabolism by which you get ketone bodies, and ketolysis is breaking it down. So what does it do? This is the only chemical, only substance, only medication which can balance both. They can work both on glutamate and the GABA. And then you have something now recently called MCT oil, and you have the decanoic acid, which is C10, which has a separate direct effect by inhibition of AMPA. So that's what happens in MCT. Your MCT gets straight through the portal vein, through the liver, is converted into ketones and into the brain. While here, long chain, all your olive oil and your groundnut oil and your whatever else you're using, sunflower oil, they have to go through the chylomicrons and get deposited in the fat and then be mobilized. So this is how it works. Very simple. You got it on one slide. Not so simple. So the summary is that all these diets reduce glycolysis, increase fatty acid oxidation. You forget what's in the middle here. Leave all this out. It works on ion channels, sodium, potassium. It works on the TCA cycle and on anaplerosis. Anaplerosis is when you got to use substances when those cells are not getting adequate, they're not getting adequate fuel, and that happens. Antioxidant is like an anti-inflammatory. So it has anti-inflammatory properties. It works on mitochondrial biogenesis and on the HDAC or the histone acetylation, which, as you know, is the reason for the epigenetic changes that you see in epilepsy. So that's how it works, right? Anti-epileptogenic, it's neuroprotective, it's anti-inflammatory. And all of this. So this is just a summary. I'm not going through the details because it's very, very long. But it works on neurotransmission, metabolism regulation, including the most important, very, very important nowadays is the altered gut microbiota, neuroprotection, neuroinflammation on the genes and on mitochondrial regulation. So let's just take two patients and show you. This is a super responder, right? So he had the Dose syndrome. Well, what do you get in Dose? That's what you get, down. In a second, he's banged his head. And if you look at this boy, look at this. He's got these two bumps on the head. Because 10, 20, 30 times a day, he would fall and bump his head. Not only that, within a few weeks, he lost eye contact, he lost speech, he lost recognition. We put him on the, he came back he came to us very early, by the third month. We thought we had lost Ram forever. He lost his speech, eye contact, recognition. Within 3 weeks, seizure free. Within 2 to 3 months, he's taking part in dramas. Today, he's in the 7th standard, doing very well in school. So totally out of no seizures. He went off the diet within 1.5 years. His EEG normalized within 2 to 3 months. Totally. All the spikes were gone, spike waves. Another patient also responded, 75 to 100 seizures a day, came to us after 2 years, tried 10 different drugs. Now, this is another thing I must tell you right here. If you have tried 3 to 4 drugs, don't waste time. Go for the diet. Because after the 4th drug, the chances of cure is 1% or 1.5% with a medication. We still get patients with 8 drugs, 10 drugs being tried. So they should not do that. You know, everyone wants to try it. I will be the one to stop these seizures with this medication. And nothing happens. If you've tried 4, nothing is going to happen. So she did get off. Number of fits now are nil, but mentally not up. So she has to be in a special school. She's never going to be able to be independent. So just look at that. If you don't start early, you're going to have a big problem. Sure. No? Oh, no. Oh, okay. So what are the metabolic therapies? I'll go now pretty rapidly. The dietary therapies, we'll be talking about these types. The 2 new ones on the board, 2DG. Your glucose is basically inhibited. And this has just come out. The ceftriaxone. So the ceftriaxone has come out very recently. So the targets are ion channel, the structural brain pathology, the molecular disruption, the neuroinflammation, stress, hormonal neurotransmitters, etc. And the last, the gut microbiota. So these are anti-epileptic, the metabolic therapies. That's the difference between all that we talked about for the anti-seizure medications. It restores your impaired bioenergetics, the mitochondrial function, the redox regulation, or the antioxidant capacity. It regulates both excitatory and inhibitory. It works on the signaling pathways. It has direct and indirect anti-inflammatory action, including on the blood-brain barrier permeability, very, very important in kids and adults who get post-traumatic injury, because the main cause of the post-traumatic injury seizures is a change in the blood-brain barrier and angiogenesis, the formation of new blood vessels. Same thing in stroke. You're going to get a lot of seniors who are now getting strokes. And the last and very important is it has an epigenetic effect on the DNA and the histones. So these are the metabolic and mitochondrial epilepsies, which work on the kindling. I told you about how it works. and on the glucose hypometabolism. Glucose hypometabolism is very important. Now, many of us didn't realize this till some time ago. And the PET scan is showing you the area of inflammation is the area where you have less of glucose uptake. So this is showing you inflammation, which is red, and blue means the glucose is not being taken up. And the same thing can be seen on an FDG PET, where over here you have blue and blue. So those are the areas of glucose hypometabolism, which will then result in, over a period of time, into seizures. So that is the role of the ketones. So what does it do? Ketones, not only an alternative fuel, but it will reduce glutamate by inhibiting AMPA and by augmenting mitochondrial biogenesis. So epilepsy has many targets, and the ketones work on these. Plus, look at that. Ketones work on all of this. Alternative fuel, yes, mitochondrial biogenesis, blocking of FFAR3, free fatty acid receptor 3, that's it, reduces it, anti-inflammatory, makes your gut microbiota good, mitochondrial pore over there. So it works on the mitochondria, and nanoplerosis is increased. The epigenetic modifications through HDAX and mTOR are reduced. It increases your brain-derived neurotrophic factor, so you get new blood, new brain cells, and it increases adenosine. Okay, and I'm just going to complete this with it has a lot of effect on ASD. I'm sure you are going to see this. And these are the actions of the ketone therapy targets in ASD. They can target more than one abnormality. And the last and the most interesting, and this is going to be a treatment of the future. But I still get at least one reference every week from all over the world. There are very few of us working on how to use ketones in cancer. Actually, it's very simple. That's Dr. Thomas Seyfried, my guru and now my friend. It's very simple. Cancer has what? Mitochondrial abnormality. That's the reason why you get cancer. Your mitochondria become abnormal much before the cancer, before a cell turns cancerous. What does the mitochondria do? Utilize your glucose. So they can't utilize glucose. So if you can drop the glucose, and we drop it to around 60 to 70 and give ketones, ketones is going to be very good for your brain, muscle, heart muscle. The cancer can't use it because those mitochondria are abnormal. So they starve. And then, of course, you have to do a whole lot of other things. It's not so simple. I thought it was simple initially, and we had tremendous results. And then after 2 years, not so good. They would become worse. And then we realized this is not the whole thing. And therefore, the targets in cancer are so many, and the ketones work at most of them. That's where they work. So now the spectrum of ketone therapy is going to expand. In SSP, I don't know, do any of you see SSP here? Yeah, subacute sclerosing panencephalitis is supposed to be a post-measles. You see it. So we've recorded the first case where we have reversed it. And he's alive and kicking since the last 4 years. You normally would die within 1.5 to 2 years. So he came to us moribund, couldn't move. He's now able to walk. Of course, if you come late, you're not going to get full. So SSP, the neurodegenerative disorders, we've got a patient with your progressive your dystonia. We've been able to halt her. And of course, the progressive supranuclear palsy, which Dr. Hui sees as an adult neurologist. It works. This is in the pipeline. But this will come through on organ failure. In the cancers, it's already being used, and in metabolic disorders. So we had the 6th Global Symposium in Jeju. Then we had one in England. And the next one, 17 to 21st September 2023. I would like to see both Hui and Tu at this. It's going to be in San Diego. It's going to be a very, very good conference. I would love to see you. We've been holding workshops all over. The latest is over here. And we've held workshops all over the place and webinars. The first The world's first webinar was held by us, and the second one too. And then the UAE took up, and then they held a webinar. And we've set up an Asian Institute for Ketogenic Therapy, where we train doctors since 2015. That's my website address. If you go on the website, it's a simple name, Ketogenic Diet India, oneword.org. So we train dietitians and doctors for a month, 3 weeks online, with once a week, we'll be coming on the Zoom and actually showing this to you. And in the last week, we have hands-on. So we'll show you the patients. You can talk to patients and see what you want to know. So you can gain a lot of knowledge from patients. And believe me, I've learned more from patients than from books. They're the ones who teach us. My eternal thanks to Dr. John Freeman and Miss Millicent Kelly and the Pediatric Epilepsy Group of Hopkins. And I believe this is going to be the diet of the future, the ketogenic diet. And yeah, come on. Am I right? Yeah, come on. Thank you.
Thanks so much. Thanks so much for your presentation. I'm very interested with your presentation. I hope in the future we have to practice ketogenic diet for many problems. For example, autism, cancer, other neurology disorder. Yes. In future, I hope we have to follow you and your colleagues some short course for ketogenic diet. Dạ. Chúng ta vừa nghe một cái phần chia sẻ của giáo sư Sanak Natha, thầy là trong ILAA Techford là về chế độ ăn sinh ceton. Thầy đã thực hành chế độ ăn này từ năm 1996 cho đến nay, và chúng ta đã nghe khá nhiều những thông tin liên quan đến lịch sử cũng như là những cái chỉ định và hứa hẹn khá là nhiều những cái chỉ định mới của chế độ ăn sinh ceton, và hy vọng không phải chỉ trong phân ngành thần kinh mà những cái phân ngành khác cũng sẽ có những cái kế hoạch để thực hiện. Cũng như thầy nói ở slide cuối cùng, chế độ ăn sinh ceton là một trong những chế độ ăn của thế kỷ 21 và chúng ta sẽ hy vọng vào điều đó. Bài báo cáo kế tiếp thì chúng ta sẽ nghe phần chia sẻ của bác sĩ Omia về chế độ ăn keto ở nhũ nhi và trẻ em. I would like to welcome Dr. Omia for your presentation, ketogenic diet in infant and children.
Thank you so much for your kind hospitality, and I want to thank Dr. Hu and Dr. Tu for the great effort they have been doing for us, and also I want to welcome you all. Dr. Omnia Rashidi from Egypt. I'm a member of the task force of the International League Against Epilepsy. In Egypt, Keto started in 2011. It started with a simple research I have done as a pilot study. Then I introduced it to the government, and the government approved to start the formula in Egypt. And we start in our center with Faculty of Medicine, Ain Shams University. And now we have more than 7 centers in Egypt. Please, if anyone need any questions during my lecture, you can stop me, and it's a pleasure for me to answer all your questions. I will give a rapid summary on ketogenic diet in infant and children. Dr. Nathan gave a very nice presentation about the mechanism, so I shall not go into the mechanism again. I shall again and again, for all who didn't know what is ketogenic diet, it is high fat. I'm increasing the fat in the diet, and fat is transferred into ketones, and ketones become the primary fuel for the brain. The only thing the parents have to do is to be careful preparation of the food of their child in a gram scale, and not in gram scale. In practical, we are trying now to use scopes which easily to be grammed, 5 gram, 10 gram scoops. It's very easy now not to use a scale, but you must be alert to everything, especially all medication the child is taking during a minor illness or anything. Our typical diet all over the world consists mainly of carbohydrates. It's around 55%, while in ketogenic diet, it's made mainly on fat, in which our calories, 90% of our calories came from fat. So we are changing our style of eating from carbohydrates main to fat main, with very adequate protein intake, which is important for the growth of our children. There are many types of ketogenic diet according to the percentage of fat content or calories we take from fat. And according, we will have many types, either classical keto diet, as we see. This is a classical, more than 80% derived from fat. We have the modified Atkins, around 70 to 80. This is my favorite diet. And we have the MCT or medium chain triglyceride. I think it will be so helpful in your country as in India. And my colleagues, the dietitian, will clarify the difference between the different types of diet and the low glycemic diet. This is our typical diet with, as you see, the red carbohydrate is more than 50%. You see the red portions here is very small, while the yellow, which is the fat, is very big. This is again the composition of the diets according to the calories we got from fat. So as we see again, in classic, 90% of our calories are obtained from fat, modified Atkins 70 medium chain, and the least is the low glycemic index. We are not using so much, or even I have never used the low glycemic. We are using the classic, and the modified Atkins, as I said, is the main practical diet in my opinion. And I'm trying now to use the medium chain triglyceride, but according to cultural habits, I see it will go with you so much. Selecting the right patient. This is very important for ketogenic diet. Maybe here you don't have a lot of options for treatment of drug-resistant epilepsy, but there are now a lot of options. We have ketogenic diet, we have vagal nerve stimulation or neurostimulation, we have surgery, we have, again, to choose the drug, the adequate drug to the type and semiology of epilepsy. So this is very important to categorize your patient. First, when you see the semiology, the type, the etiology, is it a syndrome or not a syndrome, the EEG characteristic. If you have a good right semiology and typing, you may have a good drugs in around 60% of cases. So drug-resistant epilepsy is diagnosed by the International League. This is an old classification, old definition, not the recent one. There is more recent. It is around 25 to 30% failed to respond to anti-epileptic, or as Dr. Nathan say, anti-seizure medication to be used. If you had resistance for 2 medication, so if you are appropriately chosen, and when I mean appropriately chosen, you mean you diagnose well the semiology and the type and the syndrome. So if you are diagnosing wrongly, you are using wrong drug, you will have a resistance. But so very important, appropriately chosen and well-tolerated drugs to have a seizure freedom, then you can use ketogenic diet. You may see in many books different indication of ketogenic diet. but it is broader than that. You can use ketogenic diet in any case of drug-resistant epilepsy with the definition, except the contraindication. So we must know by heart the contraindications first, because if you use the contraindication in the contraindication ketogenic diet, you will worsen your patient and he may die, because usually it is an inborn error of metabolism. So take care of the contraindication only, and you can use it broadly in any drug-resistant epilepsy. So this is the absolute contraindication. It is an inborn error, usually in acyl-carnitine profile and fatty acid oxidation defects. It is a fat, and carnitine is needed for the fat to be transported. So how we can use fat diet in patient with acyl-carnitine or fatty acids or beta oxidation defects, also in pyruvate carboxylase deficiency and porphyria, and they are a rare condition, but I can explain in the Q&A if you want, because it needs more explanation beyond this lecture. So we have this clear absolute contraindication. It's very clear. It's rare, very rare. So you can use keto in many patients. The relative contraindication is related to our nutritionist, which is to maintain adequate growth of your patient and adequate nutrition. And usually this doesn't happen at all. It's never happened with me along the last 12 years. Our nutritionists and dietitians are so clever, they maintain nutrition. Surgical focus identified by neuroimaging and video EEG. It is a relative contraindication. Why? Because for this condition, the best is surgical intervention and lagenectomy. Okay, if it's not accessible to surgery or the parents refuse surgery, you can go to ketogenic diet. Again, if you feel that the parents are not adherent, are not compliant in spite of your trials to become adherent, again, it becomes a relative contraindication, because you are doing nothing. You're just doing a good, large effort, and the parents will never become adherent. So you must tailor the ketogenic diet not only to the patient, but to his family, or parents, or caregiver. The third is ketogenic diet in the intensive care unit. We are going to give propofol. So if you are going propofol with keto diet, you are going to go easily into propofol syndrome. Otherwise, you have all indications you can use ketogenic diet in any case of drug-resistant epilepsy, and this which have been declared by the International League Against Epilepsy. The first is any case of drug-resistant epilepsy except the contraindication. The second and the third are two inborn errors of metabolism. The only cure for them is ketogenic diet. It is glucose transporter 1 deficiency and pyruvate dehydrogenase deficiency. And again, these two, if I spoke, I will have the whole workshop. So it's not so common, but when we search for GLUT1, we found a lot of GLUT1 in Egypt. Again, there is a great success in many diseases using the keto. I will mention only the important one. I think all Dr. Nathan, what his case, it was DO syndrome or myoclonic atonic, one of the drug-resistant epilepsy in which keto diet proved to be very effective. Dravet syndrome, again, is one of them. Fever-induced refractory epilepsy, fires. I don't know you encounter fires a lot or no. Okay. To myself, I cannot diagnose fire easily. I think it needs many, many investigation to reach that it's have no cause. So infantile spasm, it's very, very effective in infantile spasm, or what known now as epileptic spasms. Epileptic spasm, you can use ketogenic diet if you don't have the drugs, especially if vigabatrin is missing. You have vigabatrin here in it? And oh, okay. You use steroids. Oh, okay. There is no contraindication even to use steroids with the keto diet today. The last papers and researchers said you can use both. So you can try to get a rapid response with your steroids and go to the ketogenic diet again. So to build up ketones, it takes some time. What's known as Otohara syndrome, or nowadays developmental encephalopathies, again, it's very effective in tuberous sclerosis. As Dr. Nathan said, it works on the mTOR directly. So it's very, very effective to use the keto diet. This was the International League Against Epilepsy recommendations. Another recommendation were given by Kossoff et al. 2018 in a different type of inborn error in childhood absence epilepsy. If it's resistant, I have never seen a resistant childhood absence. In Landau-Kleffner, you know Landau-Kleffner, epileptic aphasia syndrome, it's very good. And very important is, to me and to you all, is Lennox-Gastaut. We see a lot of Lennox-Gastaut. So it is very efficient in Lennox-Gastaut. I have many patients on keto diet. Again, the Rett syndrome, and as Dr. Nathan said, the subacute sclerosing pancreatitis. Pre-diet evaluation and counseling is very, very important. We don't have this time or teams in our countries, so we do it. You are not obliged to do it in the same clinic to have the dietitian and nutritionist and the nurse and the educator. Try your best. If you do it, it will be the best. But if not, you can be individualized and you can counsel. The neurologists have to counsel your ketogenic diet as well as the dietitian, the educator, the chef. Everyone must counsel and counsel and counsel so that the parent could adhere to your diet. The goals of Keto Clinic team is to assist and advise patients when they encounter possible complications that either cause or exacerbated by being on diet. With the beginning of our diet, the parents and even the doctors in the GP in the hospital, what are going to do with this patient? How is going to take his fluid? Well, what is about his antibiotics? What about his antipyretics? All that you must counsel and advise. And if you have flyers, it will be so good. If you have a WhatsApp group, or we in Egypt, in the Keto Clinic, I have a WhatsApp group. All the patients, many of us are present on this group, doctor, nurses, educator, so we can help the patient with any minor illness or any condition. First of all, you must change all the drug to tablet form or sugar-free form. Take care of the kidney stones. You are in India, in Egypt, in Vietnam, hot countries. So the possibility of renal stone and recurrent urinary tract infection is common. So take care of that. A lot of fluids, the patient must ask, a good temperature as you can. And we give, after we have done a research, we give oral citrate routine in all our patients. And again, if they are taking special drugs, as you will see later. Take care again if you have gastroesophageal reflux, dyslipidemia, poor oral intake, and cardiomyopathy. Adequate information should be provided to the patient. To the strict adherence, vitamins and minerals must be added. Tolerability. This patient will be easy to start in hospital or as an outpatient. How he's going to do his ketone monitoring, you must teach them. You must be realistic with the parent's expectation. It is not a magic. As if you are using a drug. You have to reevaluate yourself after 3 months. about its efficacy. And no drug or there is nothing in the whole world to clear all the cases of drug-resistant epilepsy. With the use of keto diet, surgery, VNS, everything, you still have 10 to 15% of patients still having epilepsy. So to get rid more than 50% of your seizures, to be less severe, to be less duration, it's improving the quality of the patient life and the family. And this is our goal. Our main potential barrier is the psychosocial barrier. You must try with them. You may not have a social worker. You may not have an educator. When we start, I start me and the nutritionist only. We don't have a team. For more than 6 years, then we have an educator and other. So you are counseling for everything. You are teaching for everything. The neurologist, the dietitian, we are doing the whole work again and again. And the most important for the patient is to have an epilepsy diary. And this we all, any epileptologist do it. Please write the time, the semiology now by the smartphones, very easy to get it on videos, and the frequency of seizures, everything, write it. And you have a small agenda or copybook. And from this agenda and copybook, together with ketone monitoring, you can manipulate the diet and together with the drugs, and you have a good combination. The medication, as I said, take care with you when using topiramate or sulfonamide, because the possibility of kidney stone. Take care about acidosis also. I have never encountered a case of acidosis while I'm using ketone, except if the patients go to severe infection or sepsis. But it never happened at the outpatient clinic. If the keto is successful, you have to wait for 6 months or 1 year before you start to withdraw drugs, except in the inborn error of metabolism, GLUT1 and pyruvate dehydrogenase deficiency. Preparing a child is a medical and nutritional preparation. The medical, as I said, the baseline epilepsy state, the comorbidity, the psychosocial, cultural, religious, to counsel about the diet. You must manipulate the diet to fit the culture in each country, so to be tolerable and palatable, and to break the psychological barrier. Teaching how to monitor glucose in blood, to monitor ketone in urine, to monitor ketone in blood. We don't have all the facilities in all countries. In our country, we just do the blood test in hospital. We don't have keto sticks for the patient. We do it in our hospital in the outpatient keto clinic. But at home, they can do it in urine. So you must provide all, again, the investigation. What are the investigations needed before the start of keto diet? It's complete blood count, electrolytes, sodium, potassium, calcium, magnesium, liver and kidney function, lipid profile, and I said the contraindication, serum, acylcarnitine profile and beta oxidation defect, urine analysis to exclude UTI, which may increase due to acidosis, calcium create ratio, urine organic acid and amino acids, if it's not done in the urinatal screen, to pick up any inborn error and treat it with a special formula, and vitamin D if available. If not, you can add only the daily requirement. This was proposed by Kosov et al. 2018. So diet initiation, what are going to do? Outpatient or inpatient? Slow or rapid titration? Hydration restriction or no? Fasting or no? How to titrate ketogenic diet? I think this will be monitored later on with our dietitian. I just give you my opinion. If you are starting your center, I prefer to admit your patient during the start. After that, you can get an experience. You will only admit the infancy below 1 year of age to monitor glucose. We never use fasting at all in our center. And now very few centers all over the world use fasting. And I said, in infants, the only one you admit because you have fear of hypoglycemia. So it's below 1 year. But to start a center, from the start, initiation, I prefer to have close monitoring because you will gain experience from that. As I said before, modified Atkins diet is very easy, can be started as an outpatient, no fasting, protein is adequate, so it is very practical and applicable diet. So if you start as an outpatient, try to be proximal to the hospital, the patient. But again, we have a patient at a great distance with a smartphone. We don't have a lot of telemedicine. We have a smartphone, and the smartphone can do everything, can video the patient convulsion, can video the patient condition. I can tell the patient, do blood glucose now, do ketone now, what is the temperature of the boy? I can guide him. And even with the GP near to him, I can guide him by phone if we have a good communication along WhatsApp or anything. So Islam is very easy to use all the diet. Inpatient admission, I think this is done for infants, and they can reach ketosis by 5 days. They are teach everything inside the hospital. Everything has advantage and disadvantage, but it's again tailored according to the patient condition and the family. You have challenges of inpatients regarding to keep the patient. It is a rapid escalation. You reach ketosis, but is it ketosis what we need only? I think not. So you may have to do that, especially if you have critical patient, unstable status epilepticus. You can do that because the family will leave her house. She will be teaching the kitchen in another environment. So it is not an easy for myself. And again, if you have a bed availability, so and the dietitian is not have an outpatient, has an inpatient. Yet the outpatient, to my opinion, is better if your patient is stable. And to begin a slow titration, it's better. Again, you will be more in my own experience. Yet inpatient, we need it for unstable. Patient has uncontrolled seizures. Patient with status epilepticus in the PQ. Patient with infection you want to control. Anything unstable patient. So low ratio, slow outpatient initiation. Overview and rationale, I think I prefer this if I'm not obliged to do the other. All patients with GLUT1, for example, are admitted. They are infants, they are small, so are admitted in hospital. They have a very rapid response within 4 days. Again, they are comparing the inpatient rapid initiation or the low ratio response. The low ratio again and slow initiation is good for the dietitian to manipulate the diet and to tailor it to each patient. But in the rapid initiation, we are giving just the formula rapidly to go to ketosis. This only if your patient is in need of that. This study compares the outpatient initiation versus the inpatient initiation in 2019, and they found there is no significant difference between them. One, I think 63% and one 65% success. Success of a diet or anti-seizure medication means more than 50% decrease in frequency of seizures and severity. Keep in mind that once initiated ketogenic diet, it works rapidly and effectively in 75%. Within 14 days, you may reach ketosis, even to 1 month. The patient is, I know he is drug resistant. I know he has seizures. You are not admitted. Let him to continue sometime. like that, until you reach your goal. The caregiver should monitor the ketone levels. The dietitian will tell how to monitor ketone in the start. Ketones are done daily. Then we start weekly, 2-3 times per week. Then if she more than 6 months, maybe every month once. The pediatric neurologist must document the child's seizures and try to resist change in anti-seizure medication, especially at initiation. In the first 3 months, try not to change so much your drugs because you don't know what is going on. Is it the drug you raise or the keto diet success? When to consider diet failure? After 3 months. Okay. If you start a keto diet to a patient and I don't know his genetic diagnosis, and he become worsen after 1 week, what I'm going to do? I'm going to stop him. As what you are doing in any drug. When you start a drug with a patient and the patient tell you there is increase in the frequency of seizure. I have 2 or 3 seizures per day. Now I has 10. So something wrong in my drug. So I must change. So you must change rapidly. If after 1 or 2 weeks, you've got worsening of the seizure frequency and severity without an evident cause, he's not stopping the drugs. He doesn't have infection or anything that interfere with your diet. And you check your diet in blood, ketone in blood, in urine. Everything is okay. Is patient worsening? It's happened once for me in my life in the 12 years. And I don't know why, I don't know the diagnosis of patient because at that time we don't have genetic diagnosis in Egypt. And even in Egypt now, we have genetic diagnosis to few patients, not all patients, because it is expensive. So be alert, you don't know the original genetic cause of my child. Okay? My take-home message is ketogenic diet should be considered earlier. Don't wait so much for drugs to act. 2 drugs when you are adequately chosen by the semiology and type of seizures. So you must shift to ketogenic diet. It has a proven efficacy. There is a good chance for improvement with keto diet. There is no chance for improvement by adding more and more drug. The possibility of using of modified Atkins diet is easier to manage as an outpatient. You need nothing except an expert dietitian. And you are all best welcome in our pediatric neurology conference in March. This is my email. If anyone wants to contact me to help him to come to Egypt, this is my keto clinic persons, colleagues, and this is the pyramids and Alexandria and the Sphinx, and welcome all to Egypt, and thank you so much.
Thanks so much. Thank you so much for your I'm very interested with your presentation. I think after we have your presentation, maybe we have to start ketogenic diet easier in the very easy. We can start outpatient clinic, inpatient also okay. But in our country, maybe we have to some difficulty to start ketogenic diet for infant because we don't have enough metabolic screening for metabolic disease in infant. We just start ketogenic diet for some special epilepsy syndrome, for example, do Ravet, something like this. So please recommend to us some experience about ketogenic diet for infant if we cannot screen metabolic disease.
I think you can exclude metabolic disease only by 3 investigations: amino acid profile in blood and urine, and organic acids. And you can, if you have to do CSF and glucose ratio in CSF and blood, you can diagnose GLUT1. This is enough to start a ketogenic diet without more and more investigation. If it is biotinase, if it is whatever deficiency, I can try the keto. I can try. And even in Egypt, for all treatable inborn, for all treatable, we give biotin, folates, and everything, B6 to all patients as a trial before we diagnose them, because genetic diagnosis is difficult. So I cannot wait for that. So we give a trial of all treatable things: vitamin B6, biotin, folate, we give. And so we start keto. Much easier than to do genetic diagnosis, I think.
Hello. So I'm back again. I wanted to ask Omnia 2 points. One was, why do you do the blood, your glucose? I don't do it at all.
Yes, it's common in infant to have hypoglycemia. It's common to see it because we use a formula. In the formula, sometimes we get hypoglycemia in some babies. Not so common, but it happens a lot below 6 months of age.
Okay, there's one point in this, Omnia, is that if you're using, even if you're using it in an infant, and if you have the blood ketone at that time over 1.5 or 2, the brain is 75% using the ketones.
Mm.
And there have been work done in the past, this is about 40, 50 years ago, where they took normal people and checked that if you do this, what level of glucose do they become symptomatic? And they can withstand blood sugars of around 50.
Yes.
So even if your blood sugar is 50, 60 or 70, your resident medical officer is going to say, this patient is in hypo. It's not in hypo because the brain is not using the glucose. It's 75% switched over to the ketones. So even if your blood glucose is low, and we are using it in patients with cancer, where we get 60, 65, and they are fine, they're doing everything. So really this blood glucose and hypo is being overstated.
I told you something. In my patients with below 6 months, they start usually in hospital. Sometimes the mother is not giving the whole formula. So, and the blood glucose, hypoglycemia for me is defined below 40.
Okay.
Below 40.
Below 40 it is hypo.
Below 40. If it happened below 40, she must have an orange juice beside her and to give. This because you are starting the diet. You don't know how the mother catch the teaching. So she may give a smaller formula, not taking the whole formula. If he's taking his formula as a book, he will never go to hypoglycemia. But if the mother is not adherent, I must let the nurse to check during the start to monitor it. Another thing, sometimes in a patient with global developmental defect or CP, again, due to ignorance of the patients we are dealing and the family, they are not giving them enough food. So they may go to hypoglycemia. This is in my culture. So I take care when she tell me for infant below 6 months, and if the mother tell me the child is not doing well at home, check the blood glucose. Okay. Again, if the mother is no ketones body in the urine, I told her, check the blood glucose. She told me 100. You're not giving the diet appropriately. You are giving sugars. So I can pick that she's going sugar. She's giving sugars and not on the diet. I usually keep my patient from 60 to 70. So it's tailored, again, tailored to my fear.
Great.
Tailored to my patient.
Okay. We don't do this. I used to do this in the initial year or so, and then I realized I didn't need it, because right now, since 1997 or so, we don't put any patient on a fasting.
We never fast. We never fast.
We don't ever
We never
fast
fast.
anyone.
We never fast. We never fast. But patient below 6 months, inpatients, I don't know how the intake of this patient. So I'm worried at the start.
Okay.
And if they are starting their center, it's better to be, to my opinion, by book. So to gain their own experience.
Great.
Okay.
Okay.
Thank you.
Okay. Thank you very much. Now, ketogenic diet in adolescents and adults. I don't know why this topic is being put anywhere in the world, because we've been using it since 1996. Like where I'm a neurologist. And in my time, we did adult, adolescent, child, and infant neurology all in once. Yes. So, we did everything. There wasn't this division between the child neurologist and the adult neurologist. But anyway, we'll go on to the next. And since this is a hot topic all over the world, I don't know why it is. And I always believe adults are just big babies. So there's really no difference at all. Yeah, there's a difference between the reasons for the adult and the childhood epilepsy. Yes. While the drug-resistant epilepsy in children would mainly be the epileptic encephalopathies and the others, of course. In adults, it would mostly be secondary to head trauma, secondary to tumors, secondary to vascular accidents, and secondary to the neurodegenerative disorders like Alzheimer's, which is now going to, zoom up all over the world. These neurodegenerations are going to come in, what we call as the non-communicable diseases or the lifestyle diseases. The compliance, of course, is less. In the children under 5 years age, you have a very good compliance. Above 9 years age, it falls. And in adults, it's about the same. So, yes, there's going to be a difference in compliance. And the other reason why the ketogenic diet was not used in adolescents and adults, because it was resuscitated by Dr. John Freeman, who was a child neurologist. And then came Charlie, who was a child. So the Charlie Foundation and John Freeman, concentrated and trained child neurologists. They did not train adult neurologists. Actually, until I went to Johns Hopkins, it wasn't being used. And then I went and I said, hey, why are we not using it in adults? Because basically its mechanism is the same. The factors which contribute to the success or the failure of the ketogenic diet is mainly adverse events and the restrictiveness and then the lack of effectiveness. In your country, I don't know whether the financial problems will be there, because ketogenic diet is more expensive than the usual diet, more of fats and things like that. And fats are more expensive than carbs. The continuation of treatment is if you have initial good results. So that's the most important. Initially, if you have a good result, even if it's not a full result, if it's not a complete control, once they see a little bit of improvement, they're very, very happy. And if they have a high frequency of seizures. So if there are severe seizures, and the high, and of course, the determination of the patient and the family support, very, very important. So let's look at the different age groups. And if you see now this responder rate, I think you also talked about it. Responder rate, the pharma companies love to use it. Why? Because if you get 50% reduction, wow, responder. The patient has responded. For what? If you got 100 seizures a day and you bring it down to 40, you got a 60% improvement. So the pharma industry is ecstatic. But the patient's relatives and the patient's parents, what? What have you done? You've done nothing. From 100 has gone to 40. I am still running after the child all the time. You haven't removed my anxieties at all. So if you see, the 50% seizure control is pretty good. All across, whether infant, child, or an adult. But this is where the change is. An infant, 100% seizure control is so much more, 1/3. And that's a big number. And as soon as you go to this, it falls to 11 to 13%. So this is in our work that we have done. And the compliance, of course, is easier in an infant. And so is the dropout rate, much less in an infant. If we tried and compared the classical ketogenic diet with the modified Atkins diet, again, you will find that above 50% seizure reduction, the classical diet does better than the modified Atkins diet. But the compliance is the problem. So obviously, if you say that, look, I'm giving you a drug, is going to be excellent, but if you got so much adverse events and side effects that people don't use it, what's the point of it? So yes, modified Atkins diet has a great role to play. A worsening of seizures we found in adults, only 8 out of the total of 300. So it's not a very great. Our study looked at 394 patients. Review in 2011, showed that seizure reduction, the so-called responder rate was 49%, but only 13% was seizure-free, almost like ours. Over here, again, if you look at it carefully, except for the adults, the 100% is almost the same. It's around 20, 25%, 30%. Compare that to the anti-seizure medication. If you have tried 4 drugs, your chances of 100% control are 1.6%. 1.6%. And here you got over 20, 25 to 30%. So that's a big, big area. While once you go to the modified Atkins, it falls, but not marginally. So modified Atkins obviously is a good choice because of the compliance issue. So this is actually looking at it mainly in the same way. So the 100% was about the same, 24 to 20%, and over 50% reduction in almost 70 to 80%. But the time taken to reach the seizure control, now this is something that I have a bone to pick with every neurologist and practitioner of the ketogenic diet. 3 months is inadequate to say it's not working. 3 months is inadequate. Look at this. Over 50% improvement. It took 12 months in infants, 21 months in children, adolescents 31 months, and in adults 18 months. It's not that if you don't get a 50% reduction in 3 months, you just, you check it out. No, you don't. And full control, 100%. In infants, it took up to 30 months. In children, 39 months. In adolescents, 33 months. And in adults, up to 65 months. So that's 5 years. It's not easy. I have a patient who was on the ketogenic diet for 8 years. And then we got her off ultimately. So it's a big struggle. How much time do we take to, do the counseling? So as a doctor, I would take over an hour. My dietitians would take about 4 to 5 hours for each and every new patient. And we take each and every new patient singly. Because remember, they have their own food habits. They have their own, the social background. You cannot take them in a 4, 5, 8 at a time. So that's the main, the major problem is there. That do not write off ketogenic diet early. If you get even a 10 to 20% reduction by the 3rd month, It will go, it may take a year, it may take 1.5 years, it may take 2 years. We did a little bit of this. We switched people who did not do well on the classical ketogenic diet to the modified Atkins diet. And we found that we could increase the seizure control by 80%. But we did that only in infants. In some of the children, we switched from modified Atkins to the CKD, the classical, and found that all of them improved. So that's another thing you can try. If modified Atkins does not work, you can switch over to the CKD. And the same with the adolescents. If it does not work, you can always switch and you may get better results. Why is this modified Atkins over here improving them? Maybe the compliance is improving. If you switch from the classical to modified Atkins, you have a better compliance. Maybe on the CKD or the classical, they are going to cheat. Means not obviously, but the mother feeds the food and the oil or the fat that's left down, the child says, I'm not going to eat anymore. I'm full. And that's where you're going to get a different ratio. So if you don't have adequate fat going in, obviously it's not going to work as well. The dropout rate now, we looked at that too. And the dropout rate is almost the same. We found a very funny thing that the dropout rate in children was very high and also in adults with the modified Atkins. But probably those are those who switched from the classical to the modified Atkins, and they were all, as it is, fed up of the whole thing. This is just to show you that, except for Barborka, who had 81%, all the rest have had 20, 25, 30. And really in adults, if you have such a small number in any trial, you really can't come up with statistics. But he had 81 patients. This is way back in the 1930s. And the success rate was 47 out of 81, which is a phenomenally high. This is the summary. I don't want to go through all of this. This was the meta-analysis where the efficacy rate is almost the same. A little less in the modified Atkins. You can see here 52% versus the 34%. So choosing the right KD, I think we've already talked to you about this, that modified Atkins is easier. And first came MCT, changed to the ketogenic diet by Huttenlocher. Then came the low GI by Elizabeth Thiel, modified Atkins diet by Eric Kossoff. Then came the RCT, Liz Neal and Helen did this in 2008. We published something on polyunsaturated fatty acid KD and found that those who failed in the classical, if you switch them to a high PUFA. So normally what we do in the classical is a mix. Saturated fatty acid, polyunsaturated fatty acid, monounsaturated fatty acid. So we switched them to only polyunsaturated fatty acid because PUFA has a separate direct action on the brain. And we wrote about it, that it has a totally different action. And we found that those who did not do well on the mixed oils, as we call it, did better on the high PUFA. Now, what are the ketones like? In the normal diet, there's negligible, 0.1 to 0.2, your blood ketones. As soon as you go to the CKD, you get moderately high. You get anywhere between 2 and 5 and 6 blood ketones. And the glucose, as we said, anywhere between 60 and 70, maybe up to 80. And if they go to the 110, this mother or the child is not feeding in the right way. MCT would be the same. The modified Atkins, you'd get probably just a little bit of ketones. You might get just 0.7, 0.8, 1. It's very unusual for you to get more than 1.5. I've never seen more than that. The blood glucose is mildly low. In LGI, really, you can get just normal ketones. The ketones really don't rise. It's only the glucose which falls. And therefore, Dr. Helen Cross spoke on, is it the fat that's working? Is it the ketones that's working? Or is it the drop in the glucose? So if you see a child who improves in the first week, now what falls? Because the blood ketones wouldn't have yet gone up that high. The blood ketone would probably be 0.5 or 0.6 or something like that. But the glucose would have definitely fallen. So in those persons is probably, in those patients is probably the lowering of the glucose which is improving. And if you speak to your patients, and we learned this from the patients that they tell you that on the days when we have a festival and the child eats a lot of sweets, he becomes worse. Very, very common. There's another thing that I want to bring to your notice, Omni, that patients have been telling me, and I used to ignore them. I used to, in fact, ridicule them. They say, whenever my child is constipated, the seizures increase. And now we know from the gut microbiota that this is true. If you have a leaky gut syndrome, and if you have got constipation from that, your microbes will change and your epilepsy will become worse. So I think we'll learn from them, not from the books, not from us. You're not going to learn from us. You're going to learn from your patients. MAD is better tolerated. If you can use MAD with MCT oil, excellent, because you're going to get C8 and C10. And yeah, we use some of the PUFA KD where we use omega-3 and omega-6. And of course, once again, I have to thank Dr. John Freeman, Millicent Kelly, and Kamoon to all of you. Thank you.
Yes. Thank you so much for your presentation. I think in our conference today, we have to some adult neurologists. I think maybe after they hear your presentation, maybe they have some experience for stock ketogenic diet in adult patient. Chúng ta đã nghe xong một số cái chia sẻ của thầy Janak Nathan liên quan đến các cái chế độ ăn sinh ceton ở người lớn và trẻ em. Thì chủ đề tiếp theo cũng là chủ đề cuối của buổi sáng. Hôm nay chúng ta sẽ nghe một lĩnh vực khá thú vị. Đó là chế độ ăn sinh ceton ở trẻ tự kỷ, trẻ có khiếm khuyết glucose, khiếm khuyết piruvat, dehydrogenase và trẻ động kinh do căn nguyên rối loạn bệnh chuyển hóa ti thể. Thì đây cũng là bài báo cáo cuối của buổi sáng ngày hôm nay. Sau đó chúng ta sẽ có cái phần nghỉ trưa và bắt đầu cho cái phiên chiều. Now, I would like to invite Dr. Sumita present your presentation now.
Hello. I have the great honor and the privilege to introduce Dr. Sumita Murugesu from Kuala Lumpur, Malaysia. She is very experienced in spite of she looks like an intern or a medical student, but very experienced. And she did her pediatrics from the IPH, I suppose that is the Institute of Public Health, Kuala Lumpur. And then she went to Japan and she worked over there and in epileptology and in EEG training. So right now she is running the ketogenic diet program in Kuala Lumpur. She has a lot of interest in drug-resistant epilepsy and the surgery in epilepsy. Sumita is going to speak on a very difficult topic, and I purposely chose her for that topic because she's very good at the presentations. So Sumita, up to you.
Very good morning. Thank you so much, Dr. Nandan. I think it's an honor to be introduced by you. So I'll speak to you about the use of the diet in these 4 different conditions. I'm going to start off by saying I'm not an expert in these conditions, but I'll try. So let's start with autism spectrum disorder. And it is essentially a neurodevelopmental disorder with the core features with deficits in social interaction, deficits in social communication, and repetitive, unusual sensory motor behavior. Let's look at the disease burden. It's an extremely high burden. It affects about 3.4 to 6.7 per 1,000 children. Boys are affected much more, 4 times more than girls. Remember that in addressing autistic spectrum disorder, you must treat the underlying comorbidities. They often have underlying epilepsy, sleep disorders, gastrointestinal symptoms, anxiety, depression, ADHD, and intellectual disability. The cost of raising a child with autism is extremely high. It costs millions of dollars. Remember, there's no effective drug for the treatment of autism. Some intervention, including special education and behavioral intervention, may help, but they do not provide, or it does not treat totally the core symptoms and the comorbidities. Therefore, neurotherapies are required, and that's where the diet comes into place. You first have to understand how the diet works in autism. This is essentially the gut-brain axis. We now know that the diet, ketogenic diet, leads to a breakdown and essentially leads to the rise of ketone bodies, which plays a pivotal role. Once it enters through the blood-brain barrier, it acts by improving energy metabolism and enhances ATP production. It exerts anti-inflammatory activity and antioxidative stress, therefore reducing neuronal death. It regulates neurotransmitters, we've learned from Dr. Nathan earlier. So your GABAergic neurotransmitters are inhibitory neurotransmitters, so it increases the GABA levels and inhibits the mTOR pathway, which decreases seizure. Right. So this was a recent systematic review looking at the papers of the use of the diet in autism. We'll go through them. I think I have time. So the first one is a child with autism and epilepsy. I think they started him on a gluten-free, casein-free diet and then started the ketogenic diet for 14 months. And they found that he had improvement in his cognitive and social skills, language function, stereotypies, and importantly, reached seizure freedom status. So again, treating autism and his comorbidities. The next, a 6-year-old child with ketogenic diet for a duration of 16 months was found to have improvement in behavior, and Dr. Nathan spoke about the FDG PET scan showed hypometabolism, meaning reduce in inflammation. Next is a small case series of 15 children between the ages of 2 to 17 on the modified ketogenic gluten-free with medium chain fatty acids. I don't know how you do it, for a duration of three months. And they found there was improvement in the core autism features, but no difference in the restrictive and repetitive behaviors. Next is probably one of the largest case series of 45 children aged between 3 to 8 who were divided into 3 different groups. The first group, ketogenic diet and modified Atkins. Group 2 was gluten-free, casein-free diet. And group 3 was a control group on a duration of 6 months. And they found that the first 2 groups showed improvement in the ATAC and CAS scores. I'll talk to you about CAS scores later. The reason why it's highlighted is because it's one of the largest studies, and the author of the paper is here with us today. Dr. Omnia is an expert of the use of the diet in autism. And so if you have questions, you ask her and not me. And next is 6 ASD patients who were on the diet for 6 months. Again, they found an improvement. More than 50% of them had an improvement in their CAS scores. And last but not least is an adult on the modified Atkins who not only improved his autistic feature, once again, treated his comorbidities as well. So this is the CAS scores. Essentially, it's a scoring system to help to diagnose epilepsy. The total score is for 15 to 60. So if you're a score of less than 30, it means you're not autistic. A score of 30 to 36 is mild to moderate. And a score of more than 37 shows severe autism. You can see that these are the papers published at onset. They all had very high scores between moderate to severe autism scores, and at 6 months to 16 months, interestingly, some of them, in fact, had become normal. This was a recent publication in 2021 proposing a shared diet KD protocol in the use of ASD, essentially highlighting the importance of dietary evaluation, instrumental evaluation of other features. Using neuropsychiatric evaluation, the CAS scores is one of them, and providing parental support. This is available easily online. So, brief conclusion, you've now learned that the diet helps in the social behavior in autism spectrum disorder by working in the 4 different pathways that I've spoke to you about, essentially the gut-brain axis. The diet varies between autistic spectrum disorder patients, and the long-term treatment can sometimes cause some nutritional deficiencies, so you need to be careful. And over conversation, dinner last night, we all agreed that it's not very easy to start the diet on someone who's autistic because they can be very fussy. So this is a boy called Everett, and his family has to be extremely, they had to design special boxes of food with Star Wars so that he would eat his diet. Next, GLUT1 or glucose transporter 1 deficiency syndrome. The diet is the treatment of choice, and you will see why shortly. So what is GLUT1 deficiency? Essentially, sugar from the vessels are transmitted across the endothelium to the brain via the blood-brain barrier through the GLUT1 transport. The GLUT1 transporter is defined or coded for by the SLC2A1 gene. So when there's a defect in the SLC2A1 gene, glucose cannot be transported from the endothelium through the brain, leading to a brain energy crisis. So how does the diet help? We now have learned the end product of the ketogenic diet is ketones. Ketone provides an alternative fuel for energy, and ketone is transported across via the MCT1 transporter. And that's how the diet helps. So GLUT1 often presents in a triad, but often in an age-specific manner. So they often present in early life with infantile seizure. Absence, early onset absence seizure should make you think of the possibility of GLUT1. You do not often get absence before the age of 3, so think about it. This picture, I do not have a video about a picture showing paroxysmal eye-head movement is common in the infantile group. And this is followed by a rapid onset of cognitive behavioral disturbances and developmental delay. And during the adolescence and the adulthood, movement disorder peaks and becomes the most prominent feature. This is a video. I don't know whether you can play it for me. I don't think he can play it for me. It's okay, don't worry. I just wanted to show you a video of absence. I think you're very familiar with absence, so we won't go through that. And if you click on the picture, does it play? Doesn't matter. It's okay, no worries. And ataxia, as I said, dystonia and ataxia becomes very prominent as the child grows older. And this is a clinical cause of somebody with GLUT1 deficiency syndrome, as I said before. Seizures peak during the infancy, right on to neonatal age, right up to infancy, and they then decrease, or they sort of plateau during the adolescent and adulthood. And movement disorder peaks as you go on in life. How do you diagnose GLUT1, or how do you suspect GLUT1? So not many of us have genetic testing. So in a child that comes in with deceleration of head growth, paroxysmal eye-head movement, early onset seizures, developmental impairment, and movement disorders, you should suspect the possibility of a GLUT1 deficiency syndrome. Diagnosis: once there is a clinical suspicion, a low CSF glucose, a low to normal CSF lactate, but a normal serum glucose and lactate is highly suspicious of GLUT1. If you have genetic testing, then a pathogenic variant in the SLC2A1 confirms the diagnosis. So this was one of the largest papers published with use of the diet in GLUT1 in 2016. There were 92 families, of which 98% of them were treated with the diet for a median duration of 5.5 years. Ranging between 1 month to 20 years. Initially, 95% of the children had more than 50% seizure reduction, and as time went by, 80% of them had 90% seizure reduction. What's important to know is there was equal percentage of children who were seizure-free receiving the KD and the MCT diet compared to the modified Atkins and the low glycemic index, but not a very significant p-value. Most importantly, 64% of them were not receiving anti-seizure medication. The most commonly used diet was classical ketogenic diet at 63%, followed by the modified Atkins. And this is the state-of-the-art recommendation that was published in Epilepsy. The diet remains the treatment of choice for GLUT1 deficiency and should be started as early as possible. If the child is under 2 years of age, a classical diet would be the treatment of choice. Most centers continue to use the classical ketogenic diet because you need to obtain a high degree of ketosis to meet the energy demands of the developing brain. And most centers believe for adolescents and adults who become non-compliant, then you can switch them to the modified Atkins diet. And all centers recommend continuing the diet for as long as tolerated by the patient. So that's Cleo, who was diagnosed with GLUT1 at 7 years of age. She's on the diet And she continues to be a volunteer in the GLUT1 Deficiency Foundation and is an outreach director. So you see how the diet changes your life. Next is pyruvate dehydrogenase complex deficiency. Essentially, it's a neurodegenerative disorder associated with abnormal mitochondrial metabolism. So what happens in PDH or pyruvate dehydrogenase deficiency is glucose is broken down to pyruvate. Pyruvate is converted to acetyl-CoA by an enzyme known as pyruvate dehydrogenase. And this is extremely important because acetyl-CoA enters the Krebs cycle to produce energy, your ATP. When pyruvate cannot be converted to acetyl-CoA, there is lactic acidosis, and this leads to the signs and symptoms including seizures and severe encephalopathy. How does the diet help? Again, by producing an alternative pathway, it produces ketone, which then enters into the Krebs cycle to produce energy. There is an age-dependent characteristic presentation of pyruvate dehydrogenase complex. With the advances of technology, there are often prenatal screening in overseas that can reveal microcephaly, ventriculomegaly, periventricular cysts, pseudocysts, dysgenesis of corpus callosum, newborns with intrauterine growth restriction, microcephaly, structural brain abnormality and lactic acidosis, and in childhood, they often present with developmental delay, seizures, axial hypotonia, appendicular hypertonia, peripheral neuropathy, dystonia, spasticity, and dyskinesia. They're quite vague. And now there are about 3 to 4 phenotypic spectrum of pyruvate dehydrogenase deficiency. So often there is a neonatal onset encephalopathy with congenital lactic acidosis and brain lesions, especially corpus callosum agenesis and a facial dysmorphism, which includes a long philtrum, a flat nasal bridge, and a large ear. They can have learning disabilities and basal ganglia necrosis, which is similar to Lee. That's what the MRI depicts. And they can have relapsing episodes of weakness and ataxia with prolonged survival.